ايوه، السلام عليكم.
وعليكم السلام ورحمة الله
عليكم
وبركاته.
السلام ورحمة الله وبركاته.
حضرتك نبدا الانترودكشن دكتوره دولة او دكتوره فاتينا؟
دولة اتفضلي حضرتك.
مساء الخير. النهارده هنتكلم على الدكتور احمد قريعي، هيسعدنا انه ويثرينا، هيتكلم على glomerular genetics. حتى الاسم is very attractive يا دكتور احمد.
ربنا يخليك يا فندم.
انتوا اكشن يعني ان شاء الله هتخليها كلها practical points ان شاء
ان
الله.
شاء الله باذن الله ان شاء الله تعالى. اوكي.
دكتور احمد يعني is a pioneer دلوقتي في
العفو.
الحقيقه بيعمل شغل جامد قوي و it's a very very difficult task. انا متاكده يعني انك اكيد درست كويس قوي وذاكرت كويس قوي علشان توصل للي انت هتعمله ده.
بنحاول نتعلم على كبر. ربنا يخليك حضرتك.
ان شاء الله خير.
طيب
اتفضل.
شكرا جزيلا. بسم الله والحمد لله والصلاه والسلام على رسول الله. Today inshallah we're going to continue. I think we have some foreigner colleagues attending, so we'll try to keep it in English as much as we can. We've as you know, we've previously started with nephrogenetics introduction to nephrogenetics, and we try to ease the way how to understand nephrogenetics, how much is it important, what are the tools, how to ask for the tests, and how to interpret different results into your clinical practice. And as well, we try to figure out that this is not an orphan type of disorders. It really accounts for more than 10% of CKD in adult population and more than 20% in pediatric age group, and up to the age of 20, more than 20% of patients with CKD are of genetic background. And it's keeping increasing because of the increasing genetic knowledge day after day. What we figured out, and courtesy for Professor Yasser Abdelhamid, who we missed today, حقيقة, for his being abroad, that he asked me to have on series of episodes each of the groups of genetic disorders concerned with the renal diseases. So we started with the glomerulogenetics, and this is the first one. And really, I'd like to call it into action, because I'll try to prove tonight that we do have a good number of cases who are really glomerular disorders in a way or another of genetic background. First, we've seen this slide before. As you can easily appreciate that there are many etiology for genetics in early onset CKD. And this can occur not only in youngsters, but also in adults. Among them is a congenital abnormality in kidney and urinary tract, and these are a good number of obstructive uropathies and of renal aplasias and hypoplasias, as well as reflux and Brun-Berry syndrome, for example. But on the other hand, there is a big number of steroid-resistant nephrotic syndrome, which leads to early onset chronic kidney disease. And this accounts for almost 10.4%, which is not a small amount of these cases. And the chronic GN, on the other hand, is another 8%. So altogether is 20% of glomerular disorders leading to early CKD are of genetic background. Definitely there is as well a typical HUS, which can be added to these glomerular disorders, renal cystic ciliopathies, and the nephrolithiasis and nephrocalcinosis, another issue. And there are others, including many other types. If you look here, for the type of genetic affection, whether it is a monogenic recessive disease, that's to say only one gene is responsible, and this gene is a recessive inheritance mode, versus a monogenic dominant disease, or a polygenic or complex disease with more than one gene, or a more complex inheritance mode. If you look, that you would find different level of penetrance, that's to say the phenotype-genotype correlation and predictive power of mutation, whether he will have the disease or not, and the onset, whether it is in adulthood or childhood or only in adulthood, not adult or child, number of affected individuals, and you can see here that the monogenic affect few but can be easily diagnosed, whereas on the other hand, the polygenic affect hundreds to thousands of patients. Like for example, when we look for the APOL1 gene and the prevalence of APOL1 gene in African Americans, and how does it affect them? The JUAS using, for example, the IgA nephropathy model with the genome-wide association studies, and how this helps to identify how IgA nephropathy now is considered in a big manner as a cogenetic disease or a genetic disorder with an what we call exposome or further exposure to environmental factor that causes the appearance of the disease. Okay, this is just a brief of how we would think about the mode of inheritance of these disorders and the incidence of the occurrence of these disorders. This just the flavor, but let's move into the real work. The SNPs or the single nucleotide polymorphism can affect the collagen pathway, collagen 4, A3, A4, and A5, and this can cause not only Alport syndrome, but other type of collagenopathies. Definitely, if you have the TRPC6 with the channelopathy or the actin 4, you can have the FSGS, and these leads to podocytopathies. If you have the BKD1 and BKD2, this leads to cystic kidney disease, although this is not a glomerular disorder, as well as UMOD is a tubulointerstitial disorder, as well as the HNF-A1B. But you can see that there, when you go for the monogenic type of kidney, genetic abnormalities, you have a high effect size, but relatively rare alleles or private alleles. On the other hand, the common alleles like the PLAR, which we know as an association with the primary membranous nephropathy, and the APOL1 in the collapsing type of FSGS, as well as other type of hypertensive and diabetic kidney disease and the progression, as well as other type related to IgA nephropathy, like the HORMAD2 and the CFH, as well as the HLA types that is commonly associated. All these, as you can see, are related to glomerulopathy, and they are common alleles, although the penetration power is not so high and the effect size is not so measurable, but you have to suspect and look for them. This is an important point to understand, that the monogenic inheritance gives a high effect size, but it's low in the prevalence, whereas the common alleles by the polygenic inheritance gives a very low effect size, but it is very common in the population, or at least more common in the population. This helps to look for the tool that you are picking to do your genetic tests. Yani exactly, you have to understand what you're looking for and how to look for. If we look for the single nucleotide polymorphism in the kidney, you would find that the collagen 4, A3, A4, A5, and some others are causing a big proportion of these disorders, which collectively in the glomerulopathy causing like 17% of all the SNPs in the kidney. 10 genes at least are known. Other 7 genes are known as well, involving glomerulopathies and others. And why this is important is just what we were discussing prior to the episode, to starting the lecture, the value in relation to transplantation. if you have a gene diagnostic panel in adult waiting for kidney transplant, you can stratify their genetic background and you can change their plan by having, for example, an unrelated donor better than a related donor for a potential genetic disorder like FSGS of primary disease or primary origin, for example, or by even being prepared to potential recurrence early on, or by even changing the plan of transplantation, for example, from a single kidney transplantation to a combined liver and kidney transplantation in cases of primary hyperoxalosis or PH1, for example. And this has been shown in this study of 142 patients who were waiting kidney transplant in a single center study. Out of these 142, 85% had a determined origin of end-stage GN disease, and 57% had CKD-U, or undetermined cause for the CKD. For those who had a determined cause of end-stage renal disease, please notice that 29%, that's to say 1/3 of these patients, almost, or even more than 1/3, had some hereditary background. For the other, the 57 patients, when they were exposed to renal gene panel, which constitutes 209 genes, they had a likely pathogenic mutation in 6 out of the 57 patients. That's to say, 6 of these 57 patients moved from being CKD-U to being CKD of known origin, and thus the hereditary group changed into 35 out of the 142, which is almost near to 30% of those patients, or 28% of those patients. This is important because these 6 persons could be a change in the pattern of their treatment plan being on the transplant waiting list. Okay, so let's try to look into practice. Now, this was just an introduction to what should we use and how to use, but let's go into action and look for cases in real life. First, what are the type of genetic defects that causes glomerular diseases or the glomerulogenetic background? These are either primary glomerulogenetic or genetic glomerulopathies, if you would call it, like glomerular endocapillary affection, glomerular basement membrane affection, podocytopathy of genetic origin, or pathogenesis of all these can contribute to the pathogenesis of congenital glomerulopathies. So almost every compartment in the glomeruli can be affected by genetic background. On the other hand, systemic genetic diseases, for example, immune diseases like in systemic immune disorder or familial autoimmune diseases, as we will see, diseases with defect in the metabolism, mitochondrial energy depletion, they can lead as well to glomerulopathy. So it's like glomerular disease can be primary or secondary to systemic disorder. These genetic glomerulopathies can be as well primary glomerular affection or secondary to some other systemic disease. As glomerulus and glomerular disorders is a sophisticated part of internal medicine and nephrology, if not the most sophisticated part, definitely the genetic study of these glomerular disorders would be somewhat sophisticated as well. If we look at the glomerular disorder affecting podocyte, endothelium, mesangium, glomerular basement membrane, and different types, let's look at that on the molecular genetic basis. You would find slit diaphragm with the nephron, the the channelopathies like the TRPC6, the actin and the myofilaments inside the podocyte, like the actin and the actinine itself, the podocin, SNP1 and 2, as you know. And if you go further to the glomerular basement membrane, you would work with the integrins, the laminin, and here is the collagen 4 with the different type of collagenopathies affecting the collagen 4A3, A4, A5, and maybe other molecules like the MYH9 and others. The taline and vinculin and the actin and the actinine, as well as the attachment points for the glomerular basement membrane, and the triple helical domain over the overall action of the glomerular structure and the mesangial connection. If we look at the mutation, at the level of mutation, at the level of the genes, there are multitude of genes which you can observe here, and we cannot spell all of them in a proper way. Of course, genetic study is not about just memorizing the names of the genes and their action. It's far beyond this, because it's a type of the high input data or the high through output data, the big data, and you need to have a special computational services and analysis system and continuous update to understand what's going on. But as you can see in this very nice arrangement in the cartoon, that FSGS works with those types of gene and as well as those, whereas the diffuse mesangial sclerosis works with those types of gene, including the NPHS1 and the COPE or CD2AP and TNS2 and others. The glomerular basement membrane affection would work with these types of gene, including the collagen A, 4A, 3, 4, and 5, where you can find the Alport and the thin basement membrane disease and the others all here. TMA, on the other hand, is working with this part of genes concerned with the complement and complementopathies, or genetic abnormalities in the complement pathway, including C3, CFB, CFH, and CFHR, and CFHI, and others, and many other genetic abnormalities. So it's very nice cartoon showing most of the genes affecting the kidney and what can be the pathology behind these genetic mutation. If we look more superficial in the way that we understand based on the pathology, IgA nephropathy would have these types of gene affected, including genes that work on the immune system and that work on the HLA as an association, and complement system as well, as we now know that complement is involved in IgA nephropathy, contrary to what previously was known, that complement is not affected in membranous nephropathy, in IgA nephropathy. In membranous nephropathy, those types of genes, starting from the phospholipase to receptor domain to other types of gene, including NFKB1, these are related to the innate immunity or the podocyte antigens, and these are related to the HLA association. Focal segmental glomerulosclerosis, the well-known genetic disease, as well has many types of these slit diaphragm protein like NPHS1 and NPHS2 for the podocin and the nephrin and others, the channelopathies like the TRPC6, and the cytoskeletal structure like the actin, and the GPM protein like the collagen A5 and the LAMA5, as well as having the APOL1 in the African American in this part of the FSGS, which is mainly concerned with the focal collapsing type of focal segmental glomerulosclerosis. So just to summarize, these are three major types of glomerular disorders that we deal with every day, and the three of them have very strong genetic background that can help not only in understanding the pathogenesis of the disease, but in planning for the treatment and in planning even for the future treatment using transplantation or even using genetic workup like working with the siRNAs and other types of genetic manipulation. This is an example for the genes. I'm keep telling the names just to try to grasp the most common of them: the podocyte, the mitochondrial level, the membrane, the lysosome and endocytic type of affection, metabolic and cytosolic, cytoskeletal scaffold, and the nuclear protein and transcription factor, the slit diaphragm, and how these affect glomerular basement membrane or receptors or endothelial cell by effect on complement or other membrane cofactor protein and other molecules. And these are the podocyte associated genetic defects. These are the very famous one: NPHS1, NPHS2, CD2AB, the actin4, and the TRPC6, and the MYH9. These types of genes are really found in some clinical forms. This is the cartoon showing how these molecules or proteins, products of the gene, act to protect the integrity of the membrane or the barrier, the filtration barrier, from the basement membrane, here from the collagen, laminin, fibronectin, and here to the integrin, and here down to the slit diaphragm and the podocyte itself. And these are the names of the syndromes that is associated with the genes and the genetic type and the protein produced, the inheritance mode, whether it's autosomal recessive or autosomal dominant. And please look here for the prevalent histology. Here's diffuse mesangial sclerosis, focal segmental glomerulosclerosis, again diffuse mesangial sclerosis, focal segmental glomerulosclerosis, collapsing type of FSGS, and again collapsing type of FSGS. Again, these are the monogenic causes of steroid-resistant nephrotic syndrome, but what I would like to stress over is this table. I meant to have these slides with the busy tables because it should be a reference to go back for it. Please look here for the gene, the inheritance pattern, whether, as we know, for Alport, for example, type 4 collagenopathies could be autosomal dominant, autosomal recessive, or X-linked, and the different mode of inheritance actually affect the different phenotype penetration and the result, and hence it even affects the prognosis of the patient and the pedigree of the family, as well as whether he can or cannot receive from a potential family member a kidney. And this is a big issue to understand, and this is a real scenarios. And I've just had a whole family of Alport syndrome, and there was a big issue about having the brother's wife as a donor for the patient, and she is a cousin of them. And the issue was very much sophisticated, and you have to go for the whole pedigree to analyze. This person was not manifested, but you can never exclude with the complicated pedigree of the family whether she can be a carrier or not. And some ethical issue can arouse. For example, she might be a carrier and she might give the disease to her son, and you don't know whether she would like to donate her kidney for her son or for her husband, brother. This is another big issue to be taken. I mean, and genetic analysis definitely can be of help to solve such potential problems. The clinical manifestation related to each one of these disorders is very important. For example, definitely with the collagenopathies, it's an Alport. With NPHS1, it's early onset steroid-resistant nephrotic syndrome, whereas with the Bodosine, the NPHS2 is early or late onset, so we might see it in our patients. If we go here for this was a patient that I've just encountered a couple of weeks ago, an MYH9. This is a non-muscle myosin, and it presents by macroplatelets. And this was the grasping point to me in the patient. He had macroplatelets in his CVC film, along with his kidney affection and the frequent bleeding disorder he had. And when I looked it over, I found that we have to look for such a disease, and he turned out to be positive for MYH9 by genetic analysis. And in this case, you can ask for a single gene or a small panel of genetic tests, which is not so much costly, for example. So having these types of genetic deficiencies or disorders in relation to the clinical presentation is something that should be borne in mind in our clinical practice, actually. And if we look here, that throughout the age domain, likewise, what we do with the nephrotic syndrome, when we say before age of 12, it's mainly minimal change. After that, you start to see the focal segmental and the membranes as well. It is the same here, definitely with infancy and childhood. The mutation in podocyte gene is higher, whereas mutation in syndromal gene, including collagen, is along the whole age spectrum is the same. The interferon therapy, lithium, and other chemotherapies affecting podocytes is definitely along the whole. This is causes of podocytopathy in general. And the APOL1 nephropathy is causing podocytopathy appears usually in older age, not in younger age. If how to look for a cause of steroid-resistant nephrotic syndrome in adults, not in children? This study, over 135 patients, more than 18 years, they were all non-syndromatic. They had FSGS or steroid-resistant nephrotic syndrome by biopsy, and they had no family history of steroid-resistant nephrotic syndrome. So those patients are not primarily suspected to be of genetic disorder, but they are all steroid-resistant nephrotic syndrome. They were all tested by NGS or next generation sequencing targeted gene of 35 gene panel for steroid-resistant nephrotic syndrome genes. And this gene panel had to be understood because, for example, when we're dealing with the phenotype of nephrotic syndrome, you don't need to look for example, ciliopathies or cystic kidney diseases, where you might add looking for tubulointerstitial nephritis, but not definitely for nephrocalcinosis or recurrent nephrolithiasis. So understanding the groups of genetic panels, which are, by the way, for nephrology, not more than 7 or 8 groups. So it's easy to understand them, and they are all based on clinical presentation. You can easily ask for them. If you are in a mess and you need more accurate, you can start by the more sensitive test, but less specific, which is the WES or the genome, whole genome sequencing, as we'll come to. Anyhow, when those 135 patients were screened by this gene panel for steroid-resistant nephrotic syndrome, we had 14, which is 10% of them had an APOL1, and 16 had some specific mutations, and 105 had nothing. So we have a total of 23 almost, or 22%, which is almost ربع العيانين, 1/4 of the patients had specific genetic mutations, and these are divided into genes that causes steroid-resistant nephrotic syndrome, and type 4 collagen gene, or type 4 collagenopathies, whether X-linked or autosomal dominant or autosomal recessive. So the message here, when you look deep, you'll find patients, and they in a considerable amount, who have genetic background, and this would help at least, which is not the only help, but the minimum of this is avoiding giving unnecessary immunosuppression, is understanding the prognosis, is looking for the rest of the family member, is planning for the future transplantation, is planning for the next generations, and the family planning and the consanguinity and the pre-implantation genetic testing, the BGT, and others of the valuable values of genetic testing and genetic understanding. Again, why, who, when, and how. This is an excellent article of how to test for steroid-resistant nephrotic syndrome in genetics. When you have an isolated steroid-resistant nephrotic syndrome, if you have accessibility and affordability to next-generation sequencing, do a gene panel. And this is the gene panel that contains the most widely distributed genes in those cases. If you cannot, do a limited sequential testing, and the limited sequential testing depends on the onset, whether it's late or very early, infantile or congenital. And based on the histology, whether the histology is FSGS, minimal change, for example, or diffuse midrangeal sclerosis, and depend on the ethnicity as well. So you would look for screening for some of the gene, and you would do some let's say tailoring of or customization of the gene that you're looking for. If we leave the podocyte and go for the glomerular basement membrane associated gene, you would find a lot of them. Example is the nail patella knee syndrome, which is a known one, the thin basement membrane disease, which you have to differentiate from Albert as being a benign, not progressive disorder. The Alport with its 3 types, the autosomal dominant, autosomal recessive, and the X-linked type. If you go for the mesangial associated genetic defects, you look for the IgA nephropathy and the IgN1, and which is there on the chromosome number 6, and it is query of autosomal dominant mode of inheritance, and it enhances the immunogenicity of poorly glycosylated IgA1, as we know now that this is a very pathogenic molecule. If we go further in the endocapillary associated genetic defect, you would go into the atypical HOS and the TTB with the Adam TS13, with the complementopathies, the membrane cofactor protein, and the factors, the cofactors of the inhibitory and stimulatory of the complement pathway, CFI, CFB, C3, and the THPD, all of them, the thrombomodulin, and you would look for the effect on the molecular background of those patients. And this is how the dysregulation of these alternative complement pathway by genetic background affect the endothelial cells and causing the HUS or the TTB to occur, the TMA, by all these candidates for complements. And definitely, as we all know, that whenever you are faced with atypical HUS, you have to divide these into two pathways, whether it's an antibody mediated, that can be good news, and these can be treated by plasmapheresis and immunosuppression after transplantation and so on, or it could be a genetic background with a genetic disorder, and in this way you have to be on ocrelizumab or other type of complement pathway inhibitors for life if you intend to transplant the patient. It's not as that much simple, but this is the main item of the story. And these are the features suggesting that HUS, atypical HUS, can be that TMA can be from a malignant hypertension rather than atypical HUS. And this is how you have the clinical clues for complement genetics, starting from dissevering the patient of TMA into primary or atypical or diarrhea positive or TMA, and how to proceed with each one of these patients in the management plan to avoid transplanting the untransplantable or who would have a recurrence with a high percentage. Back to the original systemic diseases that is associated with glomerular pathology, including diabetic nephropathy, and the gene involved in progression of diabetic nephropathy to a diabetic patient versus others who do not have the progression. As you know, 40% of diabetic patients would have some sort of diabetic nephropathy. Why not the rest? We tend to say the level of glucose control and the comorbid conditions and the proteinuria and so on, so on, so. But really, the genetic background plays an important item in this issue, and we have to look it for. Lipoprotein glomerulopathy is another issue. Fabry's disease, the Elkeraie, which we had a patient of, that was diagnosed by histopathology and proven later by genetics, the glycogen storage disease and others, all these are systemic disorders that affect the kidney, and definitely the Apple one is the one that affects the kidney in different domains of the kidney disorders, starting from the CKDU, sickle cell disease, the progression of albuminuria, chronic GN, the high VAN, and the bad prognosis with the HIV-associated nephropathy, the primary FSGS, and specifically the collapsing type of FSGS. It impairs transplant survival, and the non-diabetic CKD in older population causing CKDU. And this is all associated with the APOL1 G1, G2 subtype. It's not only that, there are trials to inhibit the APOL1 pore formation and reduce the proteinuria resulting from that by molecules that is now in phase 2 clinical trial over 16 patients in Mississippi University. So you can see that based on these genetic abnormality, you can have some sort of target therapy. Things are not that much easy. Definitely, patient can present in a typical way. Monogenic form can go unrecognized. Heterogeneity can be a misleading between the different phenotypes. Genome-wide approaches like exome sequencing and genome sequencing definitely have a high superior diagnostic yield, but it gives you too much data that might be perplexing in some situation. In the following few slides, I'm going to show you cases from only one center over only less than 12 months, definitely. It all started like in last August. So it's almost an 8 months now, or 10 months now. And this is results, and these tests have been done to our patients and have been sent through Professor Khalda, and we got the reports back. As you can see, this is a whole exome sequencing for a patient that show you, and I just have a bigger view, show you that this patient in a summary have a heterozygous pathogenic variant detected in the CFHR2 gene. And this detected variant is in concordance with the patient phenotype. This is the conclusion. Likewise, when you read the conclusion of WIFAM in a pathology report, but you need to understand the rest of it because it's very important information. You need to understand what is the likely pathogenic or pathogenic variant, what is the variant coordinates, and what zygosity, is it hetero or homozygous, and what is the classification, which is one of 5, as we mentioned before: pathogenic, likely pathogenic, VUS or variant of undetermined significance, benign or likely benign, the mode of inheritance, whether it is autosomal dominant or autosomal recessive or X-linked or whatever. And then these are pieces of information for table interpretation, including the additional information of the exome of the patient, which you can find some other types of abnormalities when you look for comparison with other, with the database, I mean, and the incidental findings that you can see here according to the American College of Medical Genetics, and the interpretation of the result and the references before the interpretation and the timing of these information, because information in genetics, according to the genetic codons and the availability, changes every 6 months to 1 year. So this patient was a patient who came for transplantation, and he was refuted based on this pathogenic variant that causes the C3 glomerulopathy in his condition, which was of genetic background and hence highly recurrent in the transplanted kidney. This is another nice story. This patient, and she was a doctor from abroad, not from Egypt, from Libya, and she came with a nephrotic syndrome, and she was diagnosed by the light and immuno as negative. Thus, it should be considered as a minimal change. But when we pursued for the electron microscopy showed some manifestations of irregular basement membrane, alternating segments of thick and thin glomerular basement membrane, and focal lamellation. Hence, it was suspected to have Alport disease. Although the patient only came with nephrotic syndrome with no other manifestation and with normal kidney function and no family history, and she was a dermatologist, a doctor, and she understands about her condition very well. She had her genetic testing sent back from her home country, and the genetic testing came back with collagen 4A4 mutation, that is VUS or variant of undetermined significance, but the interpretation in the view of her pathology is appropriate to prioritize the patient clinical finding as positive and to provide the necessary genetic counseling to himself and his family members. And this is an important issue. So this is a proband. This is a first member in a family. Although she is heterozygous, and this can be in an autosomal recessive pattern, which that's why is not manifest with her, but definitely she can carry it to her offspring, specifically when her husband is her cousin. So, I mean, you had from a pathology, what directed you to have a genetic testing, and it turned positive and of important finding. This was another patient who presented by renal impairment and gradual progression of kidney disease. And please look here that his serum C3 and C4 were normal, ANA was negative, but he has a renal impairment, and the biopsy showed chronic thrombotic microangiopathy with focal C3 deposits. And the patient at that time was severely hypertensive. So we thought that the hypertension is the cause of the TMA that he had. But because he was insisting on kidney transplantation, when he progressed over a few months, actually he progressed over only 7 to 8 months into end-stage disease, and he started dialysis, and he pursued kidney transplantation. So we told him that you have to be subject for genetic analysis before going to transplantation. Then we had the whole exome sequencing, and it showed up a heterozygous variant of uncertain significance again, but in the complement factor H region, which shows that this complement factor H is associated with the phenotype that we had in the pathology report, which is the thrombotic microangiopathy. If you look down here for the phenotypes that is associated with this mutation in complement factor H, this can be the basal laminar drusen or the hemolytic uremic syndrome, the atypical one, or the macular degeneration age-related one. And this was a result of the patient, and the interpretation is a variant of uncertain significance. In this patient in particular, you cannot stop here, because variant of uncertain significance is a borderline result. It's like the equivocal in case of ANA. You cannot tell the patient you have lupus or you don't have lupus. So you have to pursue another type. That what we did in this patient is we looked for another tool of analysis, which is the Sanger test. And the Sanger test showed likely pathogenic variant in CFH domain, and this variant with this mutation is reported in the literature to be associated with the atypical hemolytic uremic syndrome. So we've solved the case. The patient is atypical HUS presented by chronic thrombotic microangiopathy, which was not manifested to us as classical HUS with LDH and hemolysis, but he presented by fake ED actually. But you now know that this patient is not transplantable based on this finding, at least for now. Let's have another patient. This was a patient with a biopsy that showed dominant C3 pattern and was suggested by nephropathologists to be C3 glomerulonephritis. And hence, because she wanted to be transplanted again, we did the genetic testing, and the genetic testing came back that it's no pathogenic or likely pathogenic. So it's benign. It's no mutation, I mean, sorry. So based upon the current scientific knowledge, there is no reportable copy number variant, and this is an important issue. It's an add-on, not in all genetic labs to be is undertaken, but it's of important value to be sure that you have a good representative result. We don't have a mutation or a copy number variant that can explain the patient disease. So this is likely a non-genetic type of complement disorder. Unfortunately, we don't have complement antibody readily made in our labs, which would be much easier and would be a better step to start with. I mean, if you ask the patient to do complement factor BB or antibody against complement B or whatever, can help you to save some of these genetic testing. But we have it the hard way, and the patient was already prepared for kidney transplant. If we move on for another domain of these types of glomerulopathies, which is in this situation related to the amyloidosis and the specifically what we call systemic auto-inflammatory or familial auto-inflammatory diseases. This patient is a good example because the patient was only solved by a simple genetic testing that we do most of the time, but we don't appreciate as a genetic tool. This patient, 63 years old male patient who presented by a renal disorder with a familial history of renal disease. His urinary protein creatinine ratio was 7 and 10 grams over 6 months, whereas his urinary albumin creatinine ratio was much less, pointing to some sort of paraproteinemia. His creatinine was 1.5, 1.4, virology negative, ultrasound showed grade 2 medical nephropathy, and albumin was low, total protein was high, and again the discrepancy implied to the paraproteinemia, has a very high ESR, and the serum amyloid A was very high, 133. Too much finding actually in this patient. In the meantime, because of the discrepancy, we thought for the protein electrophoresis, and it was positive, although the M band was not very high, less than 3 grams, but still positive, and IgA with lambda light chain. Because of the serum amyloid A that was high, we did a genetic testing by PCR for FMF, and it showed a positive heterozygous result in this mutation at the A7445 locus. Again, the bone marrow showed 16% infiltration with the plasma myeloma cell. So what do we have now? What do we have for proteinuria here? Do we have an AA amyloidosis by FMF or an AL amyloidosis by multiple myeloma or other cause of myeloma-related nephropathy? This was the PCR positive at heterozygous, and at this phase, most of us would consider this that he solved the problem and the patient is already diagnosed as FMF because of this MEVF mutation that turned to be positive at this locus. Should we do a renal biopsy? Definitely in such a patient, you would go and you would do a renal biopsy to understand, at least by immunohistochemistry, what's the AA or AL in the kidney. And these are the type of hereditary amyloidosis in the kidney, hereditary and non-hereditary actually, AL and AH and AA, and different type of hereditary amyloid, transthyretin and LECT and others. To our astonishing result, that we find that in these data, 391 gene on familial Mediterranean fever with the different types of mutations added, because this is a continuous updated site. We find that the mutation that we had, the A7445 or whatever, is a mutation of uncertain significance. So it could not be, or it could be not the cause for the patient amyloidosis. So when we started to look back for the serum amyloid A related genes and protein, you would find that serum amyloid A actually lies on chromosome number 11, the short arm, and we have 4 types of serum amyloid A, A1, A2, and these are the most pathogenic types. A3 is a pseudogene, it's not there actually, and the A4 is a normal gene to be present. And this paper is a very nice one that showed just a couple of years ago that you can have a genetic type of amyloid A in a hereditary way that is not related to FMF, because in most cases we thought that serum amyloid A is a disease of chronic inflammation, chronic infection, or familial Mediterranean fever, and that's it. Whenever you find a serum amyloid A or an amyloid A deposits in the kidney, you would go for these causes. No, it's not always the case. Hereditary amyloid A is there, and this is a French family that here you can see the pedigree and the affected person, and 12 genetically affected family member showed promoter mutation in serum amyloid A1, and the mutation increases basal transcriptional activity and causes deposition of amyloid, and specifically the amyloid A1. And these family, or most of the family members, were treated with tocilizumab, the interleukin-6 that we all know had been given extensively in the era of COVID, the Actemra, and it showed partial control of the disease in those patients. So it's another part of hereditary type of amyloidosis that is related to AA, and these monogenic autoinflammatory diseases or systemic autoinflammatory diseases is not only the FMF, there are the TRAPS and the MVK and the CAPS. And if we look deeper in these types, they are not so much rare as we thought, and they are not only in children. Maybe the CAPS are more in children and infancy, especially the SINCA and the neurological type. Here again is the different more major types of these monogenic autoinflammatory diseases and the affection all over the body. Please mind that amyloidosis occurs in FMF in up to 75%, does not occur too much in the MKD type, but it occurs in the CAPS and in the TRAPS by 1/4 of the cases. There are some different method of treatment between the 4 of these, and the treatment are there and they are available and they are of beneficial value. This one is treated by colchicine or interleukin-1. The 4 of them you can give interleukin-1 inhibitor. But like anakinra, here colchicine, as we all know, is of value. It's not of value here or there, but here you can use interleukin-6 inhibitor or TNF inhibitor as well. And the difference in the phenotype between the 4 of them, the FMF, the TRAPS, the MKD, and the CAPS is exemplified here for your reference. And do we have to request genetic tests for those patients? I would just give you the flavor. Yes, you have. You have to ask for pre-symptomatic genetic testing in asymptomatic family members, or prenatal diagnosis, pre-implantation genetic diagnosis can not be supported for all systemic autoinflammatory diseases, but in families with severe diseases as SINCA and NOMID, which occurs in children, you should do it as a pre-implantation genetic test. Challenges, there are challenges, but still you can go and you can ask, and I'll skip those couple of slides and show you directly the algorithm of how to ask for genetic testing in those patients. Definitely, FMF is widely used, as you all know, and we ask for PCR for FMF gene. Just I need to remind you that there is an extended gene panel. The classical gene panel tests for only 12 mutations, and there is another extended gene panel that tests for another 10 to 14 mutation, and these can be on exons 2 or 10. If you find it negative on one and there is a high suspicion, you can still ask for the extended gene panel, and this is available in Egypt in most of the labs now. This is the French algorithm of Montepied of how to go for a patient with suspected autoinflammatory monogenic disease. If you have a strong specific suspicion based on the clinical background, you ask for a specific gene panel, whether FMF, Sanger for FMF exon 10, or if the patient had a vasculitis, fever, CRB, or decreased ADA2 activity, you ask for Sanger for ADA2. And if he has increased mevalonic aciduria, you ask for Sanger for mevalonic K only, kinase, mevalonate kinase inhibitors or whatever. If you don't have that strong suspicion, you go for multidisciplinary expert meeting, and from that expert meeting, which is the genetic counseling, the pre-test genetic counseling. Likewise, when we ask Professor Khalda and Professor Ghada for their help for our patient, then you can go for next generation sequencing either by panel or by whole exome sequencing or even by whole genome sequencing. And based on this, you can have a confirmatory genotype, and then you can get the final report with the definition of the patient and his situation. This is how you use it, and this table is just exemplifying what we've just mentioned about the monogenic inflammatory disorders. And these are the major types, the TRAPS and the MKD or the hyperimmune globulin D, and the amyloidosis that is related to it. And please take care of this point. Renal impairment is always the revealing symptom of amyloid A in those patients. Those patients would present with nephrotic syndrome or end-stage renal disease, pointed out with kidney amyloidosis, and they present at these situation with renal impairment. You do a biopsy, you find amyloidosis. If you dig deeper, you can find that those patients have some sort of these familial autoimmune diseases, as we've just mentioned. The CAPS is the fourth type of these, and these are the biological therapies that can be used, as well as the colchicine, with the value and the in which case you would use each of them. And as we mentioned, that anakinra or interleukin-1 can be used in the four diseases: the FMF, the MVK, and the TRAPS and the CAPS, all of them. Colchicine only in FMF, and tocilizumab only in the TRAPS. I would end up with what we've done in Alexandria. This was a genetic analysis for complement factor H and MCP in a cohort of patients in Alexandria University. We tried to look for what there in patients with proliferative GN by doing the genetic testing for those patients. To cut a long story short, we had the WES, and then we had targeted gene panel first, and then we have Sanger confirmation for the novel variant that we found. And we really found a novel variant that was not reported to be of pathogenic significance previously. in Egyptian population. This was in complement factor H, known as C14S. And when we tried to correlate this, we found that it is very highly correlated with the activity in the lupus group, correlated with the patient prognosis for the lupus nephritis and the other C3 glomerulopathy subtype, and hence we thought that this is a common among Egyptian patients with lupus nephritis and post-infectious glomerular nephritis, not in healthy population, and that this can be correlated with the activity index, denoting that there can be a prognostic value of determining the genetic background of our patients. I'll stop by this slide. We've not finished with all the types of glomerulopathies. We've just had an idea about the genetic affection of different compartments of the glomerulus, as well as systemic genetic disorders that can affect the glomerulus and lead to secondary glomerulopathies of genetic origin. These are other types of chronic GN that can present late by renal impairment or end-stage renal disease, and they still have genetic background. And this is not by any means related to the nephronophthisis, nor ciliopathies, nor autosomal dominant tubulointerstitial kidney disease, but they are in the differential diagnosis of chronic GN. And this might be the clue for the next episode about the tubulointerstitial genetic background of our diseases. And we'll have a break here. And I'm happy to start discussion with the distinguished panel that is with us tonight. Thank you, and sorry for the lengthy lecture.
Thank you very much, Professor Ahmed, for this very informative presentation. And thank you also for the very interesting cases that you have presented and for the interpretation of the reports of the whole exome sequencing and giving us an idea how to read this report. Thank you also for sharing with us the experience of Alexandria University and your publication. Really, it was very nice talk. Thank you very much. And
thank you very much, Professor Ahmed. I think the last two slides are very informative and clinically very practical.
Thanks, Dr. Dawlat.
You mentioned the clinical situations and clinical diseases. When do we proceed for a genetic study?
Yes.
In a case of GN? Can you summarize this again? If you are faced with a case of histologically or histopathologically proven GN, which type are you going to proceed, enthusiastically with the genetic studies?
Okay.
Does it have to be a steroid-resistant nephrotic syndrome or a focal segmental?
Yes. So to sum it up, there are patterns in the clinical picture and patterns in the pathological report that points to a genetic background that cannot be neglected. For example, if it is a steroid-resistant nephrotic syndrome in adulthood or adolescent or children, definitely, we should sought genetic help before proceeding into changing immunosuppression and giving the patient cyclosporin after cyclophosphamide, after longitudinal courses of steroid with no response. So we have to look for genetic background in these cases because we can save the patient of unnecessary immunosuppression. And definitely we can plan for next move in transplant or not. On the
Right.
other hand, if a patient is suspected to have a TMA, whether this suspicion came from a clinical scenario of full prone TMA, or even just from a biopsy proven TMA with no widely explosive systemic TMA, we have to look for genetic background in complementopathies.
Okay.
In patients with a strong family history of collagenopathies like Alport and other diseases of collagen background, if a member of the family presents without previous diagnosis, I mean, if I have a diagnosis of a brother based on genetic testing and on, for example, pathology and audiometry and so on and so forth, and I'm sure of the diagnosis that the patient is Alport, I wouldn't examine his brother for being Alport as well or not when he presents with the same phenotype. I might do the genetic testing to verify whether he's a carrier or not a diseased person, if he's sound and okay for other concerns like consanguinity and marriage and pre-implantation genetic and so on.
But if he's
If we had
phenotypically an
a
Alport,
patient,
you still go for genetic study? If he's a frank
no,
Alport,
no,
you don't.
no, definitely no, definitely no. I wouldn't go for genetic study if he's previously diagnosed from another family member that fits into the pedigree of the family.
All right. We have another question.
On another,
Uh,
yes.
in cases of FSGS in Egypt, the Egyptians, is there any specific frequency of the APOL1 in Egypt? We are not Africans, but we are.
Actually, I think this was not tested enough. I had one patient proven based on a family ancestry of Sudanese. Her grandmother was Sudanese from southern Sudan.
Right.
But and the patient herself was not, and she presented by collapsing FSGS and rapid progression of CKD, and she was young. She was only, if I remember, 19 or 20 years old, and the issue was that she looks like Caucasians actually, because her father has a Turkish ancestor,
right?
But her mother had a Sudanese ancestor.
Yeah.
And that's why she turned out to be APOL1 related. So we don't know how much do we carry of these genes in our background actually, and I think it deserves to be studied. It deserves to have because after all we're close to the African in a way or
very
another.
close. Yes, it keeps saying African Americans, but we are not very far from Africa.
Yes,
and we have lots of focal segmental cases. Yeah,
definitely, yes.
Yeah. Okay. This was a very, very rich talk, Professor Correa, and I think you have to go on and on and on all the time to just highlight the importance of genetic filtering of cases. You really filter the cases.
Hopefully, inshallah, with the cooperation of the team all together, inshallah, and we're moving on, alhamdulillah. And we've just started the whole issue of nephogenetics just less than a year ago, and it's moving, alhamdulillah. And many meetings have been done, and many collaborators, and we came to now collaborate with people from المعهد القومي ما شاء الله للبحوث والمركز القومي. Professor Khalda and Professor Ghada are with us tonight. I'd like to hear their comment. I'm sorry to prevent in your presence. I should not have done that.
You'd like to hear their comment about the lecture?
العفو يا دكتور أحمد. Such a wonderful lecture. بجد such a wonderful presentation. يعني perfect knowledge, perfect presentation, very systematic.
يعني I would never have spoken about the genetics of nephrological condition the way you presented it. Thank you very much.
ربنا يخليكي. Thanks for the flattering. يعني والله يا دكتورة غادة يعني I hope إن أنا ما كنتش عكيت في الجيناتكس بارت.
لا أنا معروفة إن أنا مش مجاملة خالص على فكرة بجد ما شاء الله. Presentation very good. Thank you very much.
Yes. Thank you, Dr. Ahmed. It's a very nice presentation. Yes, as Dr. Ghada said, yes, it's very in details for the genetic background. It's very amazing. Actually, we get the benefits from your presentations more and more. Yes, it's very nice presentation.
الحقيقة إنه في part within the presentation that I got learned from you, which is that not all genetic tests are alike. For example, I've shown the test from inheritance and the test from NGC, and you can find that the test from inheritance came like in an XJet or whatever. It came like in 4 pages, and it gives you the full details and the full data and the interpretation. Whereas the other test came in 1 page with just a small summary that does not give you what you need to understand about the patient. So this is another issue. And we, inshallah, yani, once we go more and more and we try to do this collaborative work all together, having the patient to have a pre-test counseling and a post-test counseling with interpretation of the result between the clinician and the clinical geneticists and the molecular geneticists, I think this can really help understanding and promoting our understanding to this group of disorders.
إن شاء الله بإذن الله.
Sure, it will help more. Yes, sure.
Yes,
I want to comment only for VUS. You comment about it with the variants of uncertain significance. Yes, the literature mentions that the variant of uncertain significance it's not neglected at all as causative, but it's still need more and more investigations. And the best thing to go through to make a segregation through the family, to confirm firstly for Sanger confirmation for the disease mutations which is identified as VUS in the patient, and after that within the family. It gives more confidence more in to be inherited, and the figure وبتدي confidence أحسن. طبعا it needs more إنها at the functional analysis علشان to prove that إنها طبعا إنها
Thank you, دكتورة خالدة. Because some people take it from just that there is segregation, that they can use it as a proof that it is the etiology of the disorder.
Yes.
I don't take that. I would never, for example, go for prenatal diagnosis with a VUS, even if it is segregating, because we found, for example, if you would remember, Dr. Khalda, some homozygous patients or compound heterozygous conditions, and we thought this is the causative reason. And then when we did the segregation, we found that one parent is having the same 2 alleles, and he's not manifesting any disease. So
for one of the parents,
always,
one of the parents,
Yes. So we can never say that through segregation, if I find that both parents are carrying the 2 VUS that we discovered in the patient, that doesn't mean they are the causative or the pathological.
Yes, it's a good point.
Still need
So testing the family member who is proven not to be diseased, if he carries the same variant of uncertain significance, this excludes that this can be the cause of the phenotype.
Yeah.
This is a very valid point.
Yes.
Can I add something? And I think Professor Ayman will agree with me that in the next transplantation chapter, if you have this panel discussion and you just pinpoint during preparation of a recipient, which patient is a must to have a genetic study. Some patients, because we don't usually do this routinely, but as you mentioned, some cases it's a must in the preparation of this patient is to do a genetic mapping for this patient.
Yes, this is an important issue. Yes, to be included in the recipient preparation.
In the
yes,
workup.
recipient workup. Yes, the recipient workup before the transplant. This is very important.
Actually, Professor Dawlat, now I told before Professor Elkeraie that in our center, we now in our center we never transplant a child with the diagnosis of end-stage renal disease of unknown etiology. Any case like this, we investigate and we have to end to a diagnosis. And I think most of our patients before being transplanted, we do the whole exome sequencing if we don't suspect, for example, a case of end-stage renal disease with small echogenic kidney, and some of these cases was proved to have primary hyperoxaluria. So we never now transplant any child with the diagnosis of end-stage renal disease of unknown etiology.
Yes, although in the preparation, I'm sorry to say, most of the patients, what is the cause of the disease unknown, and they just
about 30% of our children come with the diagnosis of end-stage renal disease of unknown etiology.
Unknown, yes.
Yeah, but we don't accept them for transplantation before being diagnosed.
And you reach the diagnosis in these people,
most of them
by genetic studies.
By genetic study, yeah.
That's very good. And the family as well, because most of them are related. I mean, in your center, most of them it's the mother and very rarely the father,
almost all of
the
them.
mother.
Yes, we don't transplant unrelated, so most of them have their donors, either the mother or the father.
So that's what I'm trying to ask. Should you screen the family as well? In some situations, are there absolute indications to do that?
We used to screen the father or the mother if they are going to donate. But now as by time we were pushed to accept the donor of a heterozygous, whether a father or a mother, in case of FSGS. So what is the value to do the test for the donor if we are going to accept the heterozygous? So we stopped doing the test for the donor. We accept the heterozygous donor, so we don't do the test whether he will be a carrier or not. We are going to accept him. What we screen for is the proteinuria, the microalbuminuria.
In the donor, for the donor.
In the donor, yes.
Okay.
But actually, because we are forced to accept him like this. Some centers refuse to use the heterozygous donor, but we do actually, yes.
Okay. And this is reflected on the degree or the incidence of recurrence if the donor is heterozygous?
No, it has no. It has nothing to do about the recurrence of the disease. It's about the donor himself.
It's for the sake of the donor's health.
Because he will have hyperfiltration with a single kidney. So we are adding a risk, a more risk being having one kidney
So it's for the sake of the donor.
Yes, of course.
Yes, but the transplanted kidney with the heterozygous trait
Nothing to do with
has
the
the same
recipient.
fate
No,
as the one with no traits.
no.
Nothing
Because
at all.
the genetic form of the FHGS has no risk of recurrence.
Yes, they don't recur. Yes.
Yes, yes.
Yes, they don't recur.
This is the fruitful part of the story. Yeah.
Yes, that's right. The genetic people don't recur. That's right.
Yes, yes.
Very nice. Yes, but he is also prone, as you were saying, for the hyperfiltration of one kidney.
Yes, of course.
That sometime he might develop FSGS himself, secondary back. Secondary.
Secondary, yes. This will be secondary FHGS and second proteinuria, yes.
Right. Thank you very much. This was a very fruitful session, Yani. Difficult but fruitful. Very
yes. Thank you,
Thank
Professor
you.
Elkeraie, very much.
Thank you, Professor Fatina. Inshallah, and hopefully, inshallah, we'll have the next meeting, inshallah, مع the transplant chapter, and inshallah, by that time we move to that transplant genomics, inshallah ta'ala.
Inshallah.
Thanks all, and have a good night, and see you soon, inshallah ta'ala.
Thank you very much.
Inshallah, we'll go through the WhatsApp group to prepare for the session. Bismillah. Inshallah.
Inshallah.
Thank you. Thank you.